Pink Run is more than a 5K run or walk. It's a chance to honor survivors, support fighters, and remember those we've lost.
Whether you've lived it or loved someone who has, this is your moment.
Join us on Sunday, October 26th, and let's walk, run, and restore hope together. To register, call 876-445-9407. Pink Run is brought to you by Jamaica Reach to Recovery.
Pink Run is powered by Catherine's Peak, Juicy Patties, Jamaica Moves, JP Foods, Supreme Ventures, NHF, and M Catering. Reaching hearts, restoring hope.
Good night, everyone. My name is Sandra Samuels, and I'm the president of Jamaica Reach to Recovery. And as usual, we meet every 7:30 on the Thursday for the month of October, as it's Pinktober, and we discuss all things breast cancer. Now, you see a little breaking news at the top. Okay, so you know that the hurricane is coming, and our run is scheduled for this Sunday. So we just want to say that we will be making an announcement tomorrow, so you can follow our pages as to what the plans are with regards to Pink Run. Tomorrow at about 10:30, we should be posting what the situation is. We will let you know as soon as we know exactly what the plan is going forward. So we want to allay all fears, all questions. By tomorrow morning, you will be told what Pink Run, when and what Pink Run will be, what date, what time, and where and when and how, and all of the above. So stay tuned tomorrow at about 10:30. Follow our pages, pinkrunjm.com, that's our website, and Pink Run Jamaica, that is our Instagram page, and Reach to Recovery, Jamaica Reach to Recovery on Facebook. Please bear with us as we sort out ourselves with regards to this impending weather. And, we still have to have the Pink Run. No matter what happens, we will be having a Pink Run. So don't worry about it. It won't be canceled. It may be postponed, but we will let you know tomorrow exactly what is happening. Tomorrow morning at around 10:30, we will let you know definitively what is happening. So thanks again for joining. Thank you. So tonight, I've had several breast cancer webinars, but we have never really spoken about reconstruction, which is a big part of post-surgery, post-mastectomy. I had a left mastectomy. I did not do reconstruction, but that was because I couldn't at the time because of my circumstances, which I'll get into a little later. So tonight we have with us the esteemed Dr. Rajeev Venugopal, and he is a consultant plastic surgeon at UHWI and director of plastic surgery training for UWI. Welcome, Doc. It's my pleasure to have you online tonight. I know you are a busy, very busy man. And so I am so grateful that you are able to join us tonight to just give us a little overview, a little what goes on, with a breast cancer survivor after mastectomy. And, I know you are there to, I don't want to say fix the issue, but certainly make us feel more comfortable, make us feel more confident, make us feel more balanced in terms of doing reconstructive surgery. So let's tell us a little bit about yourself. I know you're a shy guy.
No, sorry.
I don't really want to talk much about yourself.
Sandra,
why do you even choose, plastic surgery? What's the story behind that?
First, I just want to thank you for allowing me the privilege to join you. And I just want to commend your team and all who have gone before you to make this initiative such an important part of our month of October, and really should continue through all the months of the year, really,
True.
because breast cancer really affects almost every single one based on the ratio of its incidence in our society. So it touches every person that you can, I think, and every family, unfortunately. So it's such an important thing that you're doing. So I think the easiest way for me to do this, Sandra, is to kind of share some of the slides I use to counsel my patients. So maybe we could just bring up my slides and then we
Okay.
can walk through this process.
Hold on. Hold on 1 second. Slide.
Great.
Okay. There you go.
So, when you think about what separates a man and a woman, it's really externally it's the breast, right?
Right.
Because it's the symbol, femininity, maternity, and obviously sexuality is a big part of what makes the breast so important in a woman and in her life. Now, whenever we see a lump in the breast, and I just want to stop at this and highlight the importance of screening, which is self-examination, as well as the using of mammograms and ultrasounds to try to detect early any of this disease process which may occur. If there's something abnormal, both on examination or on radiology, you have to sample and confirm the diagnosis. Then after that process, usually they go through what we call staging, which is a set of different scans, looking at your lungs, looking at the bones, and really what the scans are trying to do is the presence of any disease elsewhere other than the breast. So the important thing is that, and we touched on this when we were at the pink table talk, that there's so many different people who should be involved in the patient management. The,
Right.
the important thing really is, I'm going to start off with the family and friends. I really should have friends there because they're probably even more sometimes closer than the family members.
Definitely so.
And then you have being kind of bounced around by a whole bunch of specialists, so it really can be quite distressing, and during this distress a lot of information is being passed on to you which cannot be fully absorbed, and having family and friends around during this process is so important. And so we are a part of the team as well, in terms of the reconstruction. So once a patient makes that diagnosis, then really there are three avenues that she can travel. I'm not going to go much into breast conservation today, and we'll concentrate on the patients who have mastectomy and choose to have reconstruction.
What is breast conservation?
So breast conservation is in a situation where a portion of the breast tissue is taken out, and that obviously that portion contains the cancer area, and the remaining breast is treated with external radiation therapy. If you do not treat with external beam radiation, there is significant amounts of chance of disease occurring in the breast which is left behind. Now, this can't be utilized for everybody and anybody, and don't want to go in based on our time constraints into that discussion. So really, the patients who are first seen by the oncologist and based on their staging process will have a discussion with us about reconstruction. So really and truly, a mandate was passed by Obama that made it essential basically for every person with breast cancer to have an opportunity to hear about breast reconstruction counseling, because
Okay.
because of how important this process is. So when we do meet, then we have to kind of decide, hey, are we going to look at the patient in terms of doing the reconstruction at the same time as the mastectomy, or are we going to do it at a delayed time? Now, 20 years ago, or I would say even longer than that, the standard of care was a delayed mastectomy. So maybe let's say more like 30 years ago. But we have enough evidence that if patients are appropriately selected, that doing an immediate reconstruction should not impact overall negatively. Although there is...
I have a question about that, but later on.
Sure. No,
Yes.
please go ahead.
Okay, so my thought process is, okay, for example, for my situation, after I did my mastectomy,
Yes.
well, I had gone through the, looking at my options, whether I'm going to do the expander, whether to do the tram flap and all of that. And then when I looked at my situation and they were asking me, do I do a total, a partial radical mastectomy, or do I do a lumpectomy? And my thing was, okay, I want to be alive at the end of the day. What are my chances if I do a lumpectomy? What is it post-treatment after lumpectomy? And it looked like a lot more treatment to me.
Yes.
So I chose to do the partial radical mastectomy. And then, because I wanted to start my treatment immediately,
Yes.
I chose not to do reconstruction. When I started treatment now, the doctor said to me, because of your age, based on where the lump was, because my lump wasn't in my breast per se, my lump was in my chest wall. They're suggesting that I do radiotherapy underneath my arm and in the chest area. Now, my thing was, if I had gone ahead and done it immediately after surgery, what would have been the situation?
Well, you bring up about a very important scenario. So when we actually see the patients, one of the things I specifically we say to the patients is that if there is any remote chance that we feel that your cancer treatment may be delayed by our procedure due to a high risk surgically in terms of complications, we opt for that patient to, just like you did, defer the reconstruction process, because at the end of the day, the reconstructive process is not as important as the mastectomy, as you clearly figured out very quickly. And I think you made the correct decision, Sandra, because like I said, any chance of, there's any doubt that there might be need to do a lot more therapy, those are the patients that we have to really spend time about and make a decision. And it's really a one-on-one decision, because there are many patients who do have that borderline situation, and my personal feeling might be that they should delay reconstruction, but they will speak, about the inability to manage life if they don't have an attempt at reconstruction. So it requires multiple meetings with the patient,
Right.
and their families. It's so important to have the family member there so that they can also speak with the patient after and remind them what the doctor said, in a less stressful environment. Because once you're in front of us, I remember somebody saying that your mind goes blank and
Yes, Carolyn says, you see the doctor's mouth moving, but you're not hearing what he said. And that is so true. I could so relate.
I could see that easily happening, So
absolutely. Very, very true. Because I believe that happened to me too.
Yes. And so I think at the end of the day, the immediate does offer some benefits, right?
Yes.
I mentioned the psychological benefits of not losing The other benefit really is that you reduce your hospitalization by one admission, because
Right.
you're going to be reconstruction. One of the other slides I have is that reconstruction is a multiple stage process.
Mm-hmm.
So you can't think that in one operation that everything will be fixed.
Right.
So, but you can definitely reduce your operations by one if you do immediate. The
Doing
aesthetic,
doing tram flap versus the expander, is
right?
that a personal, or is the
Yes,
doctor
and
would normally recommend which one you do?
I'm gonna delay that question as we
Oh,
go
for the
further
further
on.
down. Okay.
Yeah.
I'm ahead
So
of myself. All
yes,
right,
no, that's
fine.
fine. Uh, but it's a good reminder what your what your question is. But
Mhm.
the other important thing is the financial benefit of lumping that together as well.
Right.
So there are some multiple benefits of the
Because
immediate
we're talking
reconstruction.
about how many hours? About how many hours?
Well, it depends on what type of surgery, and we'll get into when we talk about the different types. So,
Okay.
so the autologous reconstruction is the reconstruction that uses auto means your own basically in medicine, and prosthetics is what everyone refers to as implants, but there are different types of prosthetics. So how do we pick which one for you is
Yes.
the question. And there are some people who, for medical reasons, would not qualify for the autologous based on, for example, suppose you've had some previous abdominal surgery. Suppose one of the common areas you talk about is the tram flap, where we go to the lower abdomen, which usually has a fair amount of fat that we can harvest from. Now, if that has been troubled in any way, for example, with a tummy tuck or a liposuction, it sometimes can interfere with the transfer. Other surgical procedures on the upper abdomen can also be a problem. So those things could create, preconceived situations for certain patients. Now, the other thing you have to look at is the overall health of the patient and what do they do, because the autologous requires a lot more recovery time.
Hmm.
So, kind of roughly 3 months after the first stage, but there's ongoing healing for about 6 to 9 months. If you're a very active person, you want to get back to your day-to-day job, even though you have that tummy that could be harvested, it may not be the choice that you want.
Hmm.
And prosthetics is basically the use of silicone shells, and that silicone shells can be filled with either, saline, which is salt water really, or silicone gel. And I'll touch on that in a minute. So, autologous can be utilized going to the back and removing the muscle they call the lats. When you hear
Right.
people in the gym and they talk about the lats, so it's the back fat that is being transferred to the front. The problem with that is that if you have anything bigger than a B cup, you probably don't have enough back fat to reconstruct. So it has limited volume. Now the other thing is the tram flap that we commonly utilize. So to simplify it, it's like instead of throwing away the fat for a tummy tuck, we
Hmm.
transfer it to the chest wall into the mastectomy site. Uh, and that's done by passing it under the abdomen and through a tunnel and up into the chest. There's more technical ways of disconnecting the blood supply and reconnecting the blood supply that we're probably about to embark on. But the standard that locally we practice is a pedicle tram. Now the other operation you people might have read about is the DIEP, which is what I was telling you about, disconnecting the blood supply and then reconnecting the blood supply, and that requires a fairly skilled set of surgeons. It requires, two teams working independently to make sure that this operation can be done in a short enough time. So
Okay.
with a pedicle operation, you're looking at somewhere between 4 to 5 hours of surgical time. So studies have shown that, and my experience have shown that if you just do one side, unless you're a very athletic person, it's not going to interfere with your day-to-day activities. Okay, so the trade-off is tummy tuck scar and reconstruction, but a longer downtime. You know, there's this risk of hernias, but we try to reduce that rate by making sure the wall is repaired with a mesh. Now, the other important thing is that this fat is very similar to breast fat because 80% of one's breast is really made out of fat too. So how when you touch a tram flap, it really feels very natural. And it's your own tissue, so it's highly likely you're going to reject it. There's, highly unlikely you're going to have any infections. And guess what? You probably don't need any revisions back, unless there's any problems specifically. So it does, its outcome can be better in the long term as well, because what happens is that uh, by the time you add up the multiple prosthetic operations throughout your lifetime, the prosthetic reconstruction actually can end up being more expensive in the long term. So now the pros, like as I said, emphasizing no rejection and it feeling normal. But again, you got to accept that there's going to be bigger scars, and again, I'm going to emphasize recovery, and these are the things that you have to, make sure that your patient understands.
Will you have feelings to the breast?
Not classically, because you've disconnected the blood supply, although there are techniques to try to reconnect some type of nerves to improve that. But it will never be exactly the same. So, for example, if we do a nipple sparing mastectomy, you'll have almost a perfect looking nipple, but it just won't function as a nipple, both from a sensory point or from a lactation point of view.
Right.
And the other most important thing is if we do one of those abdominal flap once, God forbid something happens on the opposite side, we can't go back to the tummy. So that other side would have to be done with prosthetics. And in my personal experience, in 25 years, I would say that I've only had 3 patients who've done a tram flap and then develops a disease process on the other side. So it's a very, very uncommon event. However, if you have some kind of genetic risk, then doing both has to be considered.
Okay.
And doing both using your own tissue, again, would mean really sacrificing both your core muscles, and that will definitely impact on your day-to-day. But I do have, 2 nurses who've had bilateral, reconstructions using their tummy, and they perform their duties, which requires a fair amount of physical work after the operation. So it can be done, but it's not my favorite go-to when you have bilateral. But some people will refuse.
I remember my girlfriend getting up sideways instead of using her abs to
exactly.
get up. Yes.
So because we're trying to protect that side which has been harvested to provide the blood flow to the fat. That's why I should have emphasized, why are we taking the muscle? We're taking the muscle so that the fat can have a good blood supply.
Okay.
And you can't take anywhere on the abdomen. I speak to the patients and I say, think of a garden hose and with a sprinkler at the end. Only the grass where the sprinkler reaches will grow. Everything outside will perish, right? So there are different zones that we can take safely, and again, that will have to be quantified with each individual patient.
Okay. Let me say good evening to the viewers that we have online and remind you that remember Dr. Venugopal is here to answer questions. Any questions that you may have. You may be a survivor and thinking about reconstruction. So if you have any questions at all, you can shoot it in the chat. I believe most of our questions normally come from YouTube, but we are live on YouTube, we're live on Instagram, we're live on Facebook. So if you want to ask any questions, don't be shy to shoot a question in the chat. There's no question that is too silly. There's no question that that Doc won't answer. He's here to answer the questions, and I'm also here to guide you into asking the right questions if you want. So yes, so Doc, you can continue. Just
So,
want to remind them because sometimes they
no,
don't
that's
remember that they can ask questions. That's why
so
we
the
choose to go live.
so the prosthetic is really using the implants, and there can be we can put the prosthetic in at the same time, or we can put in what's known as an expander, which is a temporizing implant. So
And that is to what? Stretch the skin?
right, that's the stretch of skin. So when you're doing a delayed, it's always going to be an expander first. But
Okay.
in the immediate, you can opt to put in an expander, and I'd say 95% or more times we're doing a double stage, simply because when you do a mastectomy and take out the breast tissue, you're basically taking away majority of the blood supply to the overlying skin, and that means that if you put in a very large implant, that implant is going to cause further pressure against that skin and may cause compromise of the blood flow to the skin, which leads to death of the skin. That death of the skin would lead to exposure of the implant. So I kind of correlate that to trying to hit a 6. So a single stage is trying to hit a 6, and
Yes, I guess you're a cricket fan.
sports, but a double
Okay.
stage is hitting a 4. So hitting a 4, you're putting in the expander, you're not going to get caught, but on the boundary rope, right? So it's going to take a longer time to get to 100, but you'll definitely get to 100. So now the other thing is when we do put in the expander, classically we sometimes would have put it under the muscle, but now there's a trend to putting it on top of the muscle. And, putting it under the muscle is a little bit more uncomfortable after surgery. Takes a little bit more time. Putting it on top of the muscles because there's been improvement in the implants, and that's why that trend is.
Okay.
So,
Is there any benefits? Does it feel different? Does it look different? What's the
well,
benefit of putting it
it can
under
look
instead
different.
of
It can look different. It really depends. If you have a very thin frame, it really can look, very less natural when it's on
Okay,
top of the muscle.
get
Uh,
you.
the muscle also can, hide the implant in terms of sometimes the implant surface will have r- rippling, which looks like wrinkles on the surface of the implant. So if you're thin, you are more likely to see the rippling.
Okay,
If it's under the muscle, because the muscle is hiding that, you won't see it in all parts of the reconstruction. So again, it requires examination, discussion about the patients. For example, a lot of patients who might be extremely, athletic and, go to the gym and don't want any disruption, going under the muscle is really going to affect them. I remember a swimmer who told me that we, when we used to put it always under the muscle, that after that operation, there was a change in her swimming stroke,
oh,
because we do have to damage the lower part of that muscle so that it sits in the right place on the chest. So I mentioned this earlier, whether we fill it with salt water, which is saline, or gel. The gel is what they call gummy bears. It's supposed to feel more natural. It's supposed to have less wrinkling, but it is not salt water. 80% of your body is salt water. So, again, it is something that we have to counsel on, and the final decision comes to the patient.
Is there a health difference?
Well,
Is one recommended over the other?
well, again, the gel was taken off the market by the FDA in 1992 because of potential queries about its safety. But several studies have shown that it is you know not much riskier than the saline. The
Okay.
saline does offer some other advantages in terms of you can adjust the saline volume. The gel is filled with one volume, so you don't have the ability to adjust that. The gel can be need a slightly bigger incision sometimes to put it in, as opposed to the saline one, and removal of that. So those are some of the other specific things that
Okay.
we would speak about and help make a decision. Unfortunately, the saline ones are more expensive because for some reason the manufacturers seem to not export to the outside the North American continent for the saline. So our local distributors will get gel implants, but if we have saline choices being made by patients, it has to be kind of single ordered because it's not one size fits all. So
Okay.
we look at the patients, and then we have a catalog that we have to look at and say, I think this is the size that and the shape and the width that will fit you as an individual.
And everybody's breast shape different. Because
Right.
even
And
with the prosthesis, you have teardrop, and then you have the one that is, I can't remember the one that I wear, because that's my breast is more wide
yeah,
than long.
right.
So do they have that in the
Yes, we do.
implants as well?
Yes. So, in our implant language, we have, it's almost like, like you talked about the width and the height ratio changing. And we call it, moderate profile,
Right.
high profile, things like that, which is kind of translating to what you just described, Sandra.
Okay. Anna wants to know, how can she make an appointment to see you
Let's see. Okay. We can talk about that after,
later
Sandra.
on? So you have to hang on, Anna, so that
So,
you can stay to the end, and then he'll give you all his details.
the pros of the prosthetic is, we're working through the same scars as the oncological team. It usually is a shorter operation. We can put an expander in probably under 40 minutes.
Okay.
You're out of hospital within a day. You'll
So it's
probably be able
really
to do that.
much less.
Yes, you'll be back, in work probably 6 weeks if all is well. The cons are, you're going to have multiple operations, even if you up to a two-stage, a minimum of two operations in the first. And then remember, it's a man-made structure which is expected to fail. So the recommendation is sometimes that, not sometimes, that 10 years is roughly where we should change out the implant, even if it's not really giving trouble. It's a foreign material, so there's a risk of it being infected. And
Oh,
there's something called capsular contracture, and I'll spend a few minutes on this. So what I correlate this to is keloids. Everyone knows about keloids, right? Which is acum, how the scar grows. Well, when we put any foreign body in, the body reacts to wall it off. And the amount of scar tissue that is created is what capsular contracture is. And capsular contracture can be so dramatic. It can take a D cup and it can make it so small that it's almost looking like a small C or a large B. So it can really, contract the size of the, what causes capsular contracture? Sometimes it just randomly happens, but one thing for sure, if you do get radiation therapy, you are going to get capsular contracture. And there's no easy way to fix this. And it's the problem with radiation. But guess what? The radiation is so important in terms of making sure that we have complete eradication of this disease process.
But Doc, how can we know if you're going to need radiotherapy
That's a very good question.
from
And
major from before you do the mastectomy?
that's a very good question, Sandra. For example, if you have disease in the armpit, the axilla, and there,
Which I did, because
right,
I take note 14 nodes and 4 were positive.
exactly. And now, at that time, 4 would have qualified. Now, they've actually reduced the number of nodes which are positive that would qualify you for radiation. So that would be one. But the size of the primary, meaning the original lump, would also guide you.
Okay.
So, for example, if you have a fairly large lump, we're talking anything over, close to 5 or greater centimeters, it's almost certain that you should get radiation therapy. Now, some of the times you may get a surprise after the mastectomy, and you find out, hey, your lymph nodes did have disease, even though you didn't know about it. And you do fall into the category who should get radiation therapy. So sometimes, we're not aware, but we do sometimes have a good idea who will get a need for radiation. And in some instances, we do leave the expander in. But like I said, if I feel that this patient has a highly aggressive disease process, I'm going to say, let's just make sure that there's no problems with the expander interfering or slowing your date to radiation. Let's just wait and do a delayed reconstruction. Okay.
Okay.
There's an extremely rare lymphoma, which is a type of lymph node cancer that has been described with implants. The incidence of this is like 1 in 370,000 of a patient. Fortunately, it's never been described in the Caribbean population, but it is something that we have to speak about if we're putting in any type of implant, whether it be for reconstruction or cosmetic purposes. And there is something called breast implant sickness, which is the medical term for rejection. And in those situations, there's not one specific test or symptom that, it's just general bad feelings. It's something like making the diagnosis of lupus. And you rule out everything that you can think of. And then you say, hey, could this be that you're reacting to the breast reconstruction material?
Mm-hmm.
So again, that's even rarer than the lymphoma.
Okay.
You mentioned earlier, that when you have reconstruction, the other side will need some adjusting. And that's the term you correctly used, which was balancing. And balancing can take basically in the shape of a breast lift, a breast reduction, or sometimes even a breast augmentation, because some people who start off with a smaller size may opt to go up in size during this reconstruction process. So our aim always is to hopefully take this negative event which has happened to you and your family and turn it around, hopefully to make it better for you and everybody else.
So is it common for persons to do the augmentation on the other side automatically? Because I'm thinking when you have reconstruction, especially using the implant. One is going to be nice and perky for the rest of your life, and then the other one is going to be struggling on its own path
I'm, well,
as you get
no,
older
that's
in the
I'm glad
downward
that
direction.
that's a very good point, Sandra. And one of the things I talk about is that when we do the balancing procedure,
Mhm.
especially a breast lift, it is more and a reduction. It's more to make you look balanced in a bra
Right.
rather than make
Balance overall.
yes. Uh,
Get you.
because as you correctly said, the implant basically looks like it's in a Victoria's Secret bra all the time, right? So there's no, but guess what? It doesn't move and feel as natural as so, I'm not encouraging both all patients to get, prosthetics
Mhm.
on, but, they're, because, you know, for a lot of women, the sensitivity of the nipple and things like that are so important for their day-to-day life that, when you do a mastectomy, even though you spare the nipple, you're losing that.
You know,
So
Doc. All right. So back in the day, when I had surgery, it was 1999. So a lot that is happening now
yeah,
was not happening then, because although I was 35,
yes,
had no kids, nobody had told me about nipple sparing
right. So
surgery, and harvesting eggs. Well, that don't have anything to do with reconstruction, but harvesting my eggs if I wanted to have children at a later date. And as a matter of fact, they told me not to have children.
right.
Was told not to have any kids.
So
So, what is the protocol now for a young person? Because from where I sit at Jamaica Reach to Recovery, we're seeing so many ladies in their 20s
right.
coming in with breast cancer. And I know on the forefront of their mind must be their sexuality and their sensuality and their image and everything. So, what is that protocol now?
So um, as I mentioned earlier, immediate breast reconstruction, 30 years ago was just coming on the scene. So, it really would have been cutting edge surgery if you had an immediate uh, breast reconstruction with a skin sparing technique. So it has become, and we actually went from, you know, skin sparing, which meant that you took the nipple, then we went to areola sparing, where the nipple, but the dark area, which is around the nipple, is saved. Because the thinking was that the nipple contains the ducts, and the ducts is where the cancer originates.
Ah,
And
get you.
then we've gone and realized, hey, in certain circumstances, we can actually do a nipple sparing mastectomy. So those are things that have changed, and this has changed over the literally over the last 20 years.
Get
So
you.
so in terms of, yes, you're right, there's so much of a younger population uh, with this disease process, and it really requires individual counseling on what should be safe. The even infertility type management can be helpful, like you had mentioned, in terms of harvesting and being able to. But each person will need to make a decision with
For
the
themselves.
oncology, with the
Mhm.
no, not I remember. I would like to emphasize the importance of the team around you to help make your decisions,
Right.
both from a medical and a social circumstances. So the final stage of reconstruction usually is the creation of the nipple areola. And as you may or may not know, you can tattoo a nipple, um, or we can use surgical techniques to try to create that projection, and we can use a skin graft to create that darkener color, but these are never as good as God's nipples,
Yes,
right? And
totally get that.
and the other problem is that, even when we create a projection, it just does not maintain it the way the standard nipple is designed, which is really another amazing feat of engineering by God. So the final thing that I always say is that, the other choice is, as you said, if you choose not to do reconstruction, there are options of an external prosthesis. I know the Reach Recovery has really pioneered the availability of the implants, but there are others who are also coming to help with this process as well.
Yes,
I think the importance here is this can be a temporizing measure, um, which every woman has. And a surprising statistic is that, only 30% of women actually go on to reconstruction, even in the first world countries.
I
So,
still have not done it.
right.
I had the assessment done, but
And, there are a lot
during
of,
that 6 hour surgery.
right, there are a lot of patients who are high functioning individuals who choose not to reconstruct, simply because I think they realize how much more downtime they may need, and they just want to proceed with their life as quickly as possible, and they recognize that reconstruction may impair that ability. So there's at the end of the day, once you make the decision and you're comfortable with it, whichever path you travel, it is the correct path for you, right? And just wanted to again to give special mentions to Jamaica Cancer Society, which has been doing a lot, and Reach the Recovery and your team. So thank you.
Thank you too. We have some questions, but uh, Marcia, you wanted to know the cost, but I would say to have a one-on-one with Doc, because as he said, all procedures are different and the cost of those procedures are vastly different, I would imagine, because one is out in a jiffy and the other is a 6 hour surgery. So it
Right.
all depends on what you choose to do, and to get a better understanding, Doc will tell you where to find him and where
Well,
can
Sandra, you can share my info and with
you are stationed at UA, or do you have a private practice
right.
separate?
I'm located at Unit 1 Seymour Park, as well as Fossil, which is in Kingston, unfortunately, right now.
Yes, Kingston seems to be the hub, but we know that there are doctors elsewhere that
Right. And actually,
that
that's
are
what I
doing.
wanted to emphasize. I wanted to emphasize that all of reconstruction that I've mentioned is available in the corporate area, at the public hospitals, as well as in Montego Bay. So, everybody can access this,
Have access.
and because we have plastic
Is it
surgeons.
covered by? Is it considered? Is it considered? Does it fall under your health insurance?
Yes, it does.
Okay,
It
it's
does.
covered under your health insurance.
It is covered by your health
But
insurance.
once you have one, once it is okay. So let me understand with regards to reconstruction. If it's just for your purposes, meaning you did not have a mastectomy, is it still covered under insurance?
If you
Like,
if you have
you're just
if
doing an augmentation because you want your breast perky. If
no,
it's
that's a totally different thing.
right,
So that's a
that is not
cosmetic.
covered
Yeah,
under.
yeah.
Right. So I just wanted to make the viewers clear that one is because it's a medical, it's not a medical procedure. What is the term I'm looking for, Doc? One
Um,
is a
one
follow up
one
after.
one one is a restoration procedure,
Restoration.
and the other would be an aesthetic procedure.
Get you. Well, are there any more questions? Because we don't want Doc to go and you don't get an opportunity to ask any questions. We did touch on if it has feelings. The answer to that is not really, because the sensitivity, the nerve endings are no longer there. Am I correct, Doc?
Yes, because just like the blood flow,
Mm-hmm.
the the nerves travel with the blood vessels
Mm-hmm.
to the nipple. So once you do a mastectomy, that whole circuit is disconnected.
Okay. And is there anybody, or let's say for argument's sake, because I've never really connected the dots. So let's say I'm diabetic.
Yes.
Would that hinder my opportunities to do a reconstruction?
Well,
Or
not
is there
not
any
not
other
not not
condition
if you're
that
not if
would
you
stop me from getting reconstruction?
well, let's say, as I said, let's say how medically strong you are. Now, let's say you're diabetic, your sugar control is perfect. You don't have any heart disease. You're otherwise well, and your blood results for what we screen for, checking your blood count, your kidney function are all normal. Then your risk shouldn't be that much greater than a person who is not diabetic. Now, if you,
Okay.
for example, if you have, heart disease, no matter what operation you do, you're adding a slight increased risk to your outcome. So, so I would say that if you do have medical problems, it may be something that would need to be optimized before doing surgery. Um, there are certain patients who may, for example, you've had a heart attack and you're not a good surgical candidate because it's happened so recently. uh, then delaying reconstruction, discussing with your internist or your medical team
Mhm.
the risk and benefits of the surgery will be done before we say no, we're not going to do reconstruction. So again, I'm going to emphasize, decision is always with a team.
And the team would be your surgeon, the plastic surgeon, your
Yes, your medical oncologist, the radiotherapist, the physiotherapist. We talked about the psychologists, um, the all of these people, and then if you have medical conditions at your internist, or if you have a specific internist who manages you, then, for example, you have a cardiologist, they would all be a part of the conversation.
get you. Those any more questions, Doc? There was another question I wanted to ask you. It slipped me just about now. I wanted to ask you about. Jeez, I should have written it down. What in terms of cancer being in your family
Yes.
and you choosing to do recon, all right, so is a decision deferred if you have cancer in your family, if let's say you were discovered with the BRCA gene,
Right.
or you found a lump and there's cancer in your family, is there a delay or it still can be done immediately?
No, those are the patients we probably do immediately, more earlier than anybody else. Because theoretically, if you've been screened and found to have that gene, you want to initiate the mastectomy before there's
Right
development
away.
of a cancer.
Right.
I mean, the gene does not mean that it's 100%, but it's fairly close to 100,
That
or
you're
even
going to get it.
that, right. So BRCA is, there are other genes which are being discovered. So, for example, I have patients who have very strong family histories, and they just don't register on the gene test that we have now. But
Wow.
but but when you just listen to that three of their mother sisters have breast cancer, their grandmother has breast cancer, and when they test for the BRCA, they don't have it. But logically, there must be a gene that we are not yet identified that this family does have. And the sad thing is that, the insurance is just black and white on this and say, oh, if you don't have the BRCA or you don't have the other PGL, you just are not covered for, this operation, which is something, I wish the insurance would individualize and really take into the history of the patient and not just rely on a test to make their decision. So maybe that is something that I would love, maybe your help with your organization as well, to lobby with us to the insurance companies about, these situations that need to special consideration.
Well, I think even with breast cancer and the policies, if I am correct, even some of the breast cancer, the stages, they only cover like early stage, like to do, I think like they only cover certain stages. Because I remember having that argument with
Well,
an agent.
I think what you might be talking about is there's sometimes where there is a term in pathology where it is in situ, you know.
Okay.
Uh, so that
So give me a
there's
little
in
break.
situ
And
and invasive.
that means it's contained in the breast.
No, in situ means that it is so early in the overall structure that
Okay.
it hasn't penetrated what we call the basement membrane. And the
Get you.
basement membrane is a layer which is thought to have some protection against spread.
Okay.
So, there's a type of cancer called lobular, which is a rarer of the breast cancers, but lobular in situ, may not be considered in the insurance as true breast cancer, and may, they will again try not to cover in those kind of situations.
What I wanted to ask you, I just remembered now. If I have done reconstruction
Yes.
and I find out that I need to have radiotherapy,
Yes. Well, we would have to just accept the radiation that damage that occurs, and then these days what we wait for is 6 months after the radiation finishes to go back
oh,
and replace that expander, because
ah,
there's so much damage that the body needs to recover from. So we found out that it's better to wait this time of 6 months out after radiation before we go back in to finish the reconstruction process.
okay. Well, I think you covered everything. I think, well, I hope the listeners uh, got the knowledge about reconstructive surgery. I certainly learned a lot tonight. Yeah, well, I'm sure Anna and Marcia will give you a call at that is at Seymour Park, and
Right.
his
So,
name is Dr.
Sandra,
Yes.
if you get their contacts, I'll reach out to them.
Okay. All
And
right. So if they want, they can inbox me. You can inbox me with your contacts at Pink Run Jamaica in the Instagram, and I will pass on your information to Dr. Venugopal, and he will reach out to you. Thank you so much, Doc. It's been a
Thank you.
pleasure again. Thank you so much. And this will be online for anybody to listen to, as long as as long as they can, and go through it bit by bit, because it was a lot of information to take in.
Yes.
And as I said, the younger people who are having um, mastectomies, they need this information, because some people sometimes don't even know that they have a choice. Um, unfortunately, sometimes, well, my experience, I don't know what the experience is now. Sometimes the doctors don't really have a lot of conversation with you about after, what happens after. Their main concern is with saving your life. But my experience is saving the life. We need to take a more holistic approach in terms of mentally. How am I going to navigate sexually? How am I going to navigate with my partner? How am I going to navigate, with being balanced? How am I going to navigate that kind of thing? Because, Doc, I probably would have done reconstruction after, I passed the stage where I could have tried to have it after, because I'm now 26 years in. Because with wearing the prosthesis, no one told me that if I didn't have that constant weight on my chest, my ribs would have shifted, which it did. So my ribs came up in the area where because when I'm at home, I don't wear my prosthesis, because I'm not a bra girl. My other breast is nice and perky. I can show off. But the other side, where I'm not wearing the bra, the ribs came up in the space. So my spine is now kind of twisted.
That's
I'm in a
interesting.
balance. Yeah. But when I went to have the the assessment, I saw it, but he pointed it out to me, that the space, the ribs shifted,
Right.
because the weight is just not there. But nobody had said that to me ever. So,
So,
I would have paid more attention, and I would have been more proactive in sorting it out.
so I think that's also a very important point that you brought up. Even with the prosthetics, for
Yes,
example, if you have a B cup breast, and
yes,
we reconstruct a B cup using prosthetics, the prosthetic weight is a lot more than the natural breast weight.
right.
So that's something that, something I've learned over the years, and I specifically counsel on,
Hmm.
because it's something, like I said, it's something that you learn with time, as you
Yeah,
experience as well.
yeah,
And there's situations sometimes where, you have a very, very heavy breast, and the after the mastectomy, the other breast actually grows. So you actually need to do some kind of reduction just to make your
reduction,
life a little bit more manageable.
comfortable,
Yeah,
and manageable.
right.
And so, would you, okay, so, no, one very important question. When you do the implant, is that for life, or there's a point in your life cycle
Yes.
that you'll have to revisit and redo?
Yes, and I mentioned that every 10 years
Oh,
is what is recommended, but most there are people who had it in for longer than 10. But it's something that the manufacturers have advised us to say, because it
mhm.
is a man-made structure which can fail. And when I mean
So
fail,
with
it
the
can.
cram flap though, that's life.
Yes, that's why I said, even though you have the downtime, and that's why overall the net amount of financial cost even it might be more the initial when you compare it, but over time, the prosthetics do add
Works
up.
out
Yeah.
right. Works out more expensive because of the constant
Repeated.
following
Yes.
up.
Right.
Okay. And is there any drawback or any suppose, God forbid, the cancer comes back?
Well, it is theoretically, if it usually comes back, it's on the surface. So, but you can have it occurring deep as well, which would be more difficult to detect with any kind of reconstruction. But
Okay.
as I mentioned, you know, those are relatively rare, but
Okay.
it's the relapses usually on the local surface.
Okay. All right. Well, I think that was a very good session. I certainly learned a lot, and I know my viewers learned a lot also. And just to recap, plastic surgery is an option post mastectomy. I mean, a lot of women. I remember when I was told that I would lose my breast. I remember standing in front of the mirror for hours, just kind of trying to figure out what I'm going to look like post surgery. And what my choice was not about what I would look like, but about saving my life. And so as an adult, we make choices um, based on our situation. And so I would like to say to my viewers, you find a lump in your breast, don't let fear cripple you. Remember, doctor spoke about options. You have the prosthetics surgery that you can put in an implant. You're in and out of surgery in no time. Or you can do the tram flap that longer, but you don't have the follow up. It's not as onerous as I don't want to use the word onerous. It's not as what the word would you use, doc? The follow up is not as much. It's not
Well,
as tedious. No, not tedious.
as well,
It's it it
it
it's for life versus you having to redo every 10 years. Yes? And so whatever decision you're making, if you do find yourself with breast cancer or diagnosed with a lump that they say is cancerous, please deal with it immediately. Cancer is time sensitive. All cancers are time sensitive. So you have options, you have various options of getting back to normalcy as best as possible. It won't be the same as Doc said, not as God's work. It won't be the same as God's work, but it sure is a very good second. So the thing is to put life first and do what you have to do. Get tested. I hope that you go out and get tested so that you can be diagnosed early stage breast cancer versus late stage, which we are seeing. Not enough people are going out to have their mammograms done or they're doing their self breast examination. Please, ladies and men, remember now, men also do get breast cancer, and we're asking everybody to feel up themselves. That's the buzzword. Feel up yourself. Know your body from neck, around the neck, behind the ears, underneath the arm, in the chest area, underneath the breast, in between the breast, in the chest area. Anywhere else, Doc? Or that's it?
no, I think the key
That's
is
covered.
on the
Yes.
chest and under the arms
Yes.
are
Because
really the primary
key
areas that
main
you want to
areas.
focus on. And to say that you want to do this maybe, a week or after your menses for the women,
Right.
because the breast will have decompressed itself, that less congested, and just like you would monitor your periods, just set that a reminder for yourself on your calendar, and get that done. Because when you learn your breast and how it feels, you are going to pick up a change before even an experienced doctor. So it's
okay.
All
right. Good night, everyone. So we have our last sorry about that. We're having some unstable internet. We have our last program next week, Thursday, same time, 7:30, where we have Dr. Roberts, and he will speak about Hugh Roberts, and he will speak on the surgery itself. Well, from diagnosis to surgery. So we'll have a wholesome understanding of what you would go through from diagnosis until treatment. So you don't want to miss that. That will also be a lot of information. Just set your alarm clocks for 7:30 next week, Thursday. If the hurricane comes, we're saying stay safe. Make sure you're prepared for whatever eventuality. And you will, as I said earlier in the program, you will hear from us about 10:30 tomorrow morning with regards to the pink run, because based on what we're seeing, the hurricane is coming. It's on our path to Jamaica. So we will let you know what the plan B is tomorrow at 10:30. Just follow our pages, and we will also put it out in the press and on the radio. So have a good night, everyone. Thanks again, Dr. Venugopal. See you again soon.
Thank you so much, Sandra.
Okay, thank you. Thank you so much.
The Pink Run is more than a 5K run or walk. It's a chance to honor survivors, support fighters, and remember those we've lost.
Whether you've lived it or loved someone who has, this is your moment.
Join us on Sunday, October 26th, and let's walk, run, and restore hope together. To register, call 876-445-9407. Pink Run is brought to you by Jamaica Reach to Recovery.
Pink Run is powered by Catherine's Peak, Juicy Patties, Jamaica Moves, JP Foods, Supreme Ventures, NHF, and M Catering. Reaching hearts, restoring hope.